I want to welcome everybody to the Live Well Kalkaska Substance Free Coalition's Coffee with the Coalition Forum. I'm Suzanne Prentice, the coordinator of the Live Well Kalkaska Substance Free Coalition and prevention specialist for Kalkaska County through Catholic Human Services Up North Prevention. This is an open and informal discussion focused on substance use disorders as well as related topics and concerns affecting the Kalkaska community and the broader Northern Michigan region. So this morning, we're welcoming Dr. David McGreaham, Medical Director of Northern Michigan Opioid Response Consortium. He's here to present on overdose trends of ages 55 plus. Also joining in on the conversation is Kalkaska County Undersheriff Dave Wagner, Kalkaska EMS Director Bill Brodin, as well as representatives of the COA. Let's see, everybody else if you could introduce yourself. Let's start with Tom Chapman.
Good morning, everyone. My name is Tom Chapman. I'm a brand new prevention specialist with Catholic Human Services Up North Prevention in Grand Traverse County.
All right, thanks. Tori?
Good morning. Tori Worth from Munson Behavioral Health, therapist and also recovery engagement coordinator.
All right, thanks. Jody?
I'm Jody McGee. I'm the director at the Kalkaska Commission on Aging.
All right. Belinda?
I am a community member, mother, volunteer, trained substance abuse coach.
All right, thanks. Lisa, can you tell us what you do at the Commission on Aging?
Yeah. I'm Lisa Anderson, Community Support Specialist for the Commission on Aging, former prevention specialist, and yep. So welcome, Tom. I used to have part of your job.
Thank you.
All
May have
right.
to bend your ear.
Mary?
Good morning. I'm a therapist with Catholic Human Services.
All right, thanks. John?
Hi, I'm John. I am a peer recovery coach from Catholic Human Services.
All right. Trooper McCulley?
Trooper Mark McCauley. I'm the community services trooper for the Michigan State Police Home Lake Post.
All right. And I can't remember your name, but it's Borden?
Jen. Jen. Hey, I'm Jen Borden. I have young kids coming up through the school system, and I also work at the Commission on Aging as a bookkeeper. So
All right.
trying to prevent them from starting.
All right. Thanks for being here. All right. So Dr. McGreaham, you can take it away.
Thanks, Suzanne. I'm going to pull up some slides and go through these with you. Suzanne already introduced me. I'm Dave McGreaham. I am the medical director of a 25-county organization called the Northern Michigan Opioid Response Consortium. I'm also involved in Face Addiction Now and several county collaboratives around the region. I want to talk about overdoses in the 55 and over age group. I'm keeping it at 55 and over because that's where the data ends. I could call it older folks, elderly folks, but it's 55 and above that are part of this database. So I want to talk a little bit about the background of how we got here, talk about older folks, how and why they're overdosing, and what we can do about it. Let's start with some basics, though, and just talk about opioids. I want to just remind you what opioids are. We have the natural opioids that come right from poppy seeds, and the semi-synthetic, which are concentrated poppy seed oils or derivatives of poppy seeds that are chemically altered a bit. And a lot of these, oxycodone, hydrocodone, Norco, Percocet, a lot of the semi-synthetic opioids were developed in the 90s and early 2000s as pain relievers, and they are great pain relievers, but we found out that they're highly addictive. And that's a big part of why we're where we are with addiction right now. And then the synthetic, which are made exclusively in labs. The big one is fentanyl, which you're all aware of. And if you look at overdose deaths, and I think everybody's probably seen this type of graph, the black line is total overdose deaths, which peaked at about 110 in 2022. That number's coming down now. But as fentanyl was developed and hit the markets around 2010, 2015, it took off and replaced heroin and other semi-synthetic opioids as the top cause of death. And now 70% of the deaths we see involve fentanyl or are multifaceted in nature, involving fentanyl and a variety of other substances as listed here. Methamphetamine is number 2 on the list as far as deaths. Let's look into 2025. And as I mentioned, the numbers are getting better. And we peaked around 23 or so, 24, and now it looks like we're going to be dropping down to about 80,000, maybe even less with total overdose deaths, which is a good thing. We're moving in the right direction. Fentanyl, as many of you are aware of, only a small dose can kill you, and you can snort it, you can inject it, or you can get it in pill form. And fake pills are out there, counterfeit pills are out there, and are a danger to everyone because they can contain various amounts of fentanyl. So let's talk about older adults. And the graph I showed you, pretty similar to this. This is deaths per 100,000 population. Synthetic opioids, that's fentanyl, is the number 1 cause of death in the 65 and older population. But what's a little interesting here is the semi-synthetic opioids, which are the pain relievers, typically pills, are the second leading cause of death. Heroin's down here. Methamphetamine is not on here. It's probably equal to the semi-synthetic opioids. But I think what this relates to is that there are probably a lot more older folks dying of pills than younger folks. So this is just another look at men versus women. It's about 2 to 1. These are 65 and older, men versus women. Again, 2 to 1 rate of deaths in the elderly age group. And it looks like it's getting more and more disparate. Women are kind of leveling off and men continue to climb. This is a study out of Toronto that looked at ER admissions for stimulants and the rate of stimulant use. This is 65 and above as well, is climbing rapidly. This is cocaine, ecstasy, and methamphetamine. But again, older adults are using stimulants just like younger adults. So I started looking at this database about a year ago, and I'm not going to get into all the things I have on this slide, but it's called the System for Overdose Surveillance, or SOS. And it looks at overdoses with deaths and EMS naloxone administration around the state. And I'll get into that in a minute, but this is where I started. And we looked at 15 counties. We actually have 25 counties, but I pulled out 15 counties a month or 2 ago to do a presentation to prevention specialists at Up North Prevention and Catholic Human Services. So the 15 counties that I looked at, only 10 of them put their numbers into this database because coroners don't always use this database. But you can see that there's a wide range of ages in the deaths reported. Highest is 35 to 44, and then the second highest is 55 and over. So these are deaths. 2 to 1 male to female, which is similar to the slide I recently showed. Traverse City accounts for half the deaths, and you can see the other areas as listed here. If you look at EMS, these are ambulances or fire departments giving naloxone to reverse overdoses, what we saw and found very interesting is instead of that even age group with the deaths, we see this huge number in the 55 and over age group. And that piqued our interest. So we started doing some deeper dives. And if I go county by county and look at Kalkaska County, for instance, again, you've got more overdose deaths in the older age group than in any other age group. Now, this spans 3 decades potentially, but it's still a lot of overdoses. This does not, the EMS reversals do not include reversals that are done by law enforcement. And often law enforcement is first on the scene. So that is not part of this database. So the number's probably higher. Here's where they're happening in Kalkaska County. When I showed these numbers in Antrim County, the sheriff was part of the presentation, was in the room, and I asked him afterwards what he's seeing in the 55 and over overdoses. And his insight was that it's often somebody that's using pain relievers and they take an extra pill or two and they go out. They call EMS, the police arrive on the scene, they resuscitate, and they take it from there. Just want to show you Wayne County. These are deaths, 55 and over, high number. These are overdose reversals. That's the point I'm trying to make here. Is this is not just a rural thing. Washtenaw County looks just like this as far as 55 and over. The other counties I've looked at downstate, very similar patterns. The overdose rate in the 55 and over with reversals is very high. So we've done some research into what might be going on. And I already mentioned that opioids in pill form are probably part of this. And if you look at that age group, they were in that cohort in the 2000s where everybody got pain relievers. And some of the older folks are still struggling with the use of pain relievers. Most are hopefully now on safe doses of pain relievers. But what's happening now is their metabolism is slowing. They're being put on multiple medications because of their age and their chronic diseases. Cognitive decline, their memory's not as good. So they're forgetting and they're misusing their pills when they don't necessarily think they're going to be misusing their pills. Baby boomers, this age group has always had a lot of drug use. And as they get older, with these other factors going on, they're dying like everybody else is dying that have used substances chronically. But I also want to mention, I think a lot of times substance use disorder in the elderly is under-recognized. I don't think physicians, neighbors, family members realize that folks might be taking too many pain relievers, might be using too much alcohol, they're using marijuana, they're using kratom, and they're getting by, but people aren't recognizing that, hey, you got an issue. You shouldn't be using alcohol starting at noon every day. You shouldn't be using marijuana 3 times a day. It might help you with your pain. It might help you with other things, but you shouldn't be using it that often. And again, you get into the metabolism in the older folks and you get into their memory declines and suddenly they're overdosing. So a lot of causes that we can think of for high overdose rates in that age group. So what can we do about it? From a medical standpoint, we probably need to do a better job of screening for substance use disorders. I don't think enough doctors, other providers are asking questions about alcohol or marijuana or kratom, and they should be asked routinely. There ought to be naloxone co-prescribing automatically, and we'll get into that in a minute. and consideration of fentanyl test strips. I think if you have somebody that's using marijuana and kratom, they're probably using other substances as well. So give them fentanyl test strips, educate them in harm reduction, and talk about whether they need help for a potential substance use disorder and screen them for it. We are also, and I've done this with Suzanne, trying to get to commissions on aging and get to the elderly population through whatever ways that we can. And this means going to them and meeting them where they're at, which is often at the senior centers or the commissions on aging. We're talking a lot about medication safety strategies, and I'm going to jump into that next. So the three big approaches with medication safety is monitor, secure, and dispose. And monitoring your medications and having a good process really is probably the key to folks not overdosing in many regards, especially if they have memory problems or other issues. There are a lot of tools out there, and I think this type of weekly planner is about 15 or 20 bucks at your local pharmacy. You can get these with timers on them and bells and whistles of all kinds that will help you remember to take your medications, but you got to put them on every week and remember to do that. Heard one story from a home care nurse that went into a home and said that she had a patient that basically filled a glass jar like a fishbowl every morning with her 10 medications, 10 different medications taken 3 or 4 times a day, and just would take out part of a handful at lunchtime, morning, dinner time, evening, and didn't really know what she was taking, but that was her system. This is a whiteboard, and this was used by a friend of mine recently that underwent surgery and was put on a variety of medications. He's got his X's under the time he's supposed to take the pill, and then he puts a little check box when he takes the pill, and then in the morning he erases the check boxes. But this is a good way to remember to take your medications, and I thought this was pretty innovative. You've also got dispensers that come with alarms, and they'll dispense your pills for you. They're expensive. You've also got iPhone apps where you can download the app, put your medications in, it'll ding. When you do for the medication, a picture of the medicine comes up, and probably not a bad way to do it. I haven't talked to anybody that's used this, but technology can be a great way to go here. So a variety of ways to increase or to improve your process for taking medications. Let's talk about securing your meds. And a couple of thoughts here. You need to store your medications properly. Be aware of interactions. Keep them out of reach, out of sight. So people, if you have people coming into your house, cleaning people, family members, friends, that they don't know where your medications are. Secure your medications. This is one way to do it, is a lock bag. And we give these out, and Suzanne, I think we've given these out at the Commission on Aging, but it's a good way to take, especially your narcotics or your benzodiazepines, your controlled substances, lock them up so that if somebody does come into your home, or if you have a guest in your home, you've got your medications locked up and secure. Another way to secure your medications personally is to get one of these, which is a lock capsule holder, basically, dispenser. Some of these have timers on them. Let's also talk about disposing medications. This is at Munson Medical Center right in the lobby. There are a lot of medication drop boxes around the region. Most healthcare facilities have them. Some pharmacies have them. Some sheriff's departments have them, or other law enforcement offices have them. But if you're not using the meds, if they're narcotics, controlled substances, throw them out. Get rid of them. Another way to do that is a technology called Deterra, where you put the pills into this bag, you add water, you shake it up, and basically the Deterra neutralizes the medications, and you just throw them in the garbage. This is a biodegradable bag. It's not plastic, so if you're concerned about environment, this does break down over time. But again, one way to get rid of your pills is to just put them in a Deterra bag and throw them away. So again, going back to interventions, I think we need to better screen folks in this age group for substance use disorders. I think simplifying prescription regimens whenever we can, using naloxone or fentanyl test strips, raising awareness, which is part of what we're doing today and with the education at the senior centers. Also educating folks on Narcan and how to administer it. And I also want to mention home care visits. They can be a real big help if you have an elderly person and you want to see exactly what their process is for giving medications to themselves. Home care can be invaluable to get you that insight. So let's talk a little bit about Narcan and what we're doing when we have the time to do it at the senior citizen centers or the COAs is show them how to give Narcan. And as you know, Narcan, typically there's a response within a few minutes. It can be immediate. It lasts for about an hour. It's the antidote for overdoses, and you can get it at a variety of places. At your pharmacy, it's over the counter. It's about $45. Your doctor can prescribe it for you, but it's no cheaper because the Medicare copays are about the same as just buying it over the counter. You can get it through the mail for free through Next Distro, and there's a video that goes along with this where they'll instruct you how to give Narcan. Your health department has Narcan, and Suzanne has been instrumental, as has the coalition, in getting naloxone distribution boxes placed around the county. And we like to tell folks where these are. And this is the map of Kalkaska County. This is what the naloxone distribution boxes look like. We typically partner with Harm Reduction Michigan to get these out there, but they're often stocked locally. This is the specific locations. So Suzanne, you got 18 in the county now, which is above average per population for any county in northern Michigan. So you're doing a great job. But this is a good resource for people in any age group that need access to Narcan for overdose reversal purposes. So when we do the presentation, one of the questions people ask is, how does Narcan work? And I think everybody in the room here is probably aware you've got these opioid receptors in your brain, and opioids land on them and basically block the pain response. And in the doses that are often taken, people feel good or get high. Narcan basically pops the opioids right off the receptors. And if you've taken enough of an opioid to affect your breathing and your consciousness, the naloxone basically, again, overtakes the receptors, pops the opioid off, and allows you to start breathing again and eventually regain consciousness. There are no side effects from Narcan. There's no abuse potential. It's okay to use in kids. It'll reverse an overdose in a pet, but it's a very safe medication to use. So when in doubt, give it. We've been teaching people how to give Narcan, and whenever I have the opportunity to teach folks, I like to show them how these dispensers, how these plungers work, and basically take one out, shoot it into the air, because a lot of people have never seen it and they're a bit intimidated by a nasal spray. If I've got enough expired Narcan, I'll let people in the room do it themselves into the air. so that they can see how it works. So next steps for me, I'm trying to work with the Michigan Department of Health and Human Services to get more information on the substances that older folks are overdosing on. And there's a database that's being queried, but it's going really slowly. So what I'm going to do today is really, I'd like law enforcement and EMS to maybe share their perspectives on what you're seeing out there, because I'd like to know if I'm on the right track with this. Are you seeing overdoses with people taking their medications improperly? Are you seeing overdoses with people using fentanyl and other illicit substances? And again, maybe we can start with EMS, but before we go there, tell me any questions on what I've presented. If not, can we start with EMS? What are you seeing out there?
I agree with you, Dr. McGreaham. The ones that we've seen have kind of been across the board, at least from an EMS standpoint, whether it's intentional, unintentional. There's definitely it depends on the area and the demographics of that area, whether it's lower income versus some of the nicer areas around the lakes or the rivers, to where sometimes it is just I was on one, it's been a couple of years, but elderly gentleman was having some pain, so his wife gave him one of her meds, and then she couldn't wake him up. So it turned out to be a narcotic. We reversed it with naloxone, and everything was fine. And it was an educational moment to where we were able to say, you need to not share your medications, understand the reality of how serious some of those medications can be. So
for that. Trooper McCauley, are you do you ever give Narcan, or do your partners ever give Narcan?
I have been on scene when it's been administered, yeah, but and people use it. I'm not sure how frequently they do. We don't like. You'd have to review all the incident reports and everything to go through. In the last year, there's been 9 overdoses that we've assisted on. But you'd have to go through each report and figure out ages and all that, and there's not a central database of that. Yeah. So I'm not sure what, there's one that says overdose on Advil even, so.
Right. Yeah, I looked at the Traverse City Fire Department EMS records on overdoses, and it's a tough database to get specific information out of, but it included antidepressants, blood pressure pills, pain relievers. It's a variety of things that folks are overdosing on. Some intentional, most not intentional, but yeah.
And we have Undersheriff Wagner on here as well.
What are you seeing, Dan?
Thank you. Yeah, usually our older clientele is either a past drug user that is trying to maybe got back into the game. Unfortunately, last month, I believe it was February, we did have somebody that passed away from that, and they were over the age of 55. They had used drugs in the past, hadn't used them for several years, and then they got back into the game, and unfortunately, it's a different game. And they died from that. And then the other ones that we use are they accidentally just it's just an accidental for them. They're trying to get a little bit more pain relief because they've been in pain for so long, and they just try and just get a little bit more bang for their buck, and they're not knowing what to get into. So that's what we see. Unfortunately, I don't have my stats right here, but it's usually about every other month. Our guys use naloxone. So we do see it quite often here. And then just for a little blurb for us, we do have a pill pod here at the jail, open 24/7, that you can put your old prescription in there. Thank you.
Thanks for that. Any other questions or comments?
Yeah, Dr. Dave, I want to thank you for bringing this more to light. Ever since I switched jobs, I saw it firsthand right away. And I think you've done a great job pointing out the reporting issues because it's probably underreported. We've watched some of our folks being wheeled out on gurneys, and I knew that they were overtaking their medications, but trying to convince both their doctor and their family members that this was happening is still an issue, because if it's prescribed by a doctor, well, how can it be bad? But I was just going to say, one of your slides, I'm glad that you pointed out loneliness as a sort of a root cause, but I would add boredom, loneliness, and boredom. Some of our folks just don't have enough to do to keep them busy. And, if one pill's good, 4 is better, and then it gets away from them and has really horrible consequences.
Yeah. I didn't get into the specifics on that, but older men that drink a lot are often very isolated. They won't go to the senior center even. They spend their days drinking and letting the time pass. They're a tough group to get to. It's the folks that go to church or go to senior centers or have some social activities are probably going to do better. Loneliness is a big thing out there, and you lose a spouse, you don't have any family close to you. It can be a big factor in using all kinds of substances. And as you mentioned, boredom can be part of it.
I think too, because we're such a rural, large county, a lot of folks, that live out in the boondocks, that are isolated, sometimes by choice, sometimes not. That definitely plays a factor. Then we have, and I'm going to say this because I'm a veteran, but veterans have an increased sort of a deal because the VA is really, I don't know if it's good or bad, but they do a lot of mail order scripts, and they just keep coming and coming. And the VA does not communicate very well with a local primary care. I have both. And if I go and have a VA appointment, I tell them, yes, send this to my primary care doctor. And I check with my primary care doctor, and did you get whatever, that the VA told me? There's certain things that are cheaper, easier, whatever, that you can get through the VA that you can't get through your primary care. And nope, they don't communicate with each other.
Does anybody else have any input or questions?
Could you explain? I mean, I know, but benzodiazepines, which some folks here might know what exactly those are, because I see a lot of folks that have those, and they think they're perfectly benign.
They're not. I mean, Valium is one of the oldest benzodiazepines. Xanax has been around for quite a while too, and there's a variety of others. They're typically used for anxiety. They can interact with opioids and a variety of other medications. Common side effect is sleepiness. They do calm you down, but there's sort of that balance between being calmed down and being sedated. Yes, they can put people out, especially in combination with opioids or narcotics. And I think there's an automatic flag now through most of the chain pharmacies. If somebody is on a benzodiazepine and an opiate, they get a call from the pharmacist at least once to see if they need to be on both. So people are trying to be more aware of it in the medical profession and the pharmacy profession, but it's a strong interaction. The other one is gabapentin, which is used for various types of pain. And that one also interacts with benzodiazepines and narcotics. And the interesting thing about gabapentin is it blocks Narcan to some degree. So if you overdose on a combination, it's harder to resuscitate folks if they're taking gabapentin and opioids.
And thanks. I didn't know that about the gabapentin, but what I could tell you is because, we do assessments where we ask people what their prescription meds are. And gabapentin is, if I talk to 10 people, 7 people are on it.
A lot.
Yep.
It's often prescribed with opioids, isn't it?
It can be. It's good for neuropathy. It's good for certain types of pain. But I think if you're seeing it in 7 out of 10, that seems like a lot. But yeah, you have to watch for interactions there.
So a while back, you were doing lots of provider, doctor-to-doctor education. Is that still going on, or has the landscape changed that the focus? Because I did see in Kalkaska improvement with prescriptions for a while, and it kind of seems like I feel like there's still a lot of overprescribing.
I continue to visit providers, but less frequently. I probably visit an office quarterly, and we talk about chronic pain, but we talk also about Narcan and harm reduction principles, and providers are very interested in where patients can get free Narcan. They're interested in SSPs, where they're located. I also talk to pharmacists. When I can, once a year, I make the rounds in a variety of counties and talk to pharmacists. And again, that conversation is as much about where can you get free Narcan for your patients and where are the SSPs. Pharmacists are very interested in the next bistro website where people can get free needles and syringes sent to their homes. Pharmacists are interested in preventing hepatitis C and HIV. And when I tell them about that, they often say, I got somebody that probably could benefit from that. But I think the conversation in most provider offices, there is a role for pain relievers.
Sure.
They work. I think the challenge is some folks have almost gone too far on the conservative side and won't prescribe anything, or won't even admit people to their practice that are on a pain reliever. And others are probably still pretty liberal. And then you've got folks that are doing a lot of chronic pain work, and they tend to get those patients because nobody else will take care of them. The other thing that's been interesting to watch in the literature and even in the providers regionally is if you're on a high dose of pain relievers, or if you're taking kratom, or if you have, excuse me, opiate use disorder, Suboxone works. So if you've got somebody on a high dose of prescription opioids, you can switch them to Suboxone twice a day. It's a good pain reliever. It's something you won't die of. because it has naloxone, Narcan in it. And something that I'm seeing more of is providers switching people from higher doses of opioids right over to Suboxone.
Just to maybe steer the conversation. So for a long time, when I was a prevention specialist, prevention was about getting them young so they don't get hooked later on. But as your stats show, and it was something that was always frustrating to me when I was a prevention specialist, because prevention, in my opinion, needs to be all age groups, not just one, but that's not the way the money was being distributed and the way they said you had to do the job. Maybe, Suzanne, is there any change with this great focus of, yep, this is where, the fatalities are happening?
Yeah, I think so. Then that's why we go into the Commission on Aging at least a couple times a year to provide this medication safety training. So most definitely.
I can tell you, Lisa, Catholic Human Services Up North Prevention invited me to talk to them. And one of the folks was happy to learn about this, because I think prevention in the elderly or working with the elderly is part of the work plan, but nobody really knew what to do. So to have a standard approach, and Suzanne's done a great job for a long time with the Commission on Aging, but I think there are other prevention specialists that really weren't sure exactly how to approach the elderly, what to talk about, and how to make it relevant. I think showing this kind of data to people gets their attention a bit, and talking about the extent of what's going on gets people's attention. And usually somebody knows somebody that's not taking their medicines right, or takes an extra pill now and then. And the number of folks using marijuana is pretty high. Alcohol is pretty high. And then the kratom discussion, people think it's benign. It's a pain reliever like any other opiate. And hopefully it's going to be outlawed soon.
Yeah, I think one of the issues that we saw in Crawford County was the prevention specialist over there was trying to get into the COA over there. And I think there's a trust or understanding issue, because they were going for it. But Dr. McGreaham, they didn't know who you were and they didn't know what it was all about. So I
stopped by last week.
Okay.
And we have a cabin not too far from that site. So I might stop by there again tomorrow.
Okay.
And I just stopped by and dropped off some data and said, have the director call me when they get a chance. It's been a week so far, but I'll stop by again.
Yeah, and I suggested that she have them reach out to the Kalkaska COA, because it would be similar. So any other questions or comments, thoughts on how
maybe my last comment, I think this age group is interested in Narcan and learning a little bit about it, because they may have a son or a daughter or a grandkid or a neighbor that's using substances. So they want to be prepared, and they want to have Narcan on hand. So we take that approach also. Having Narcan isn't just about saving your spouse if they take an extra Norco. It's about maybe saving somebody who's taken too much medicine or who was truly overdosed. I think a lot of people now know somebody that's overdosed or somebody that's using substances. So I think the Narcan discussion helps.
Yeah, absolutely. And Jody, any update on having a box placed at the COA? We have an extra box actually sitting out in my garage.
I just have to ask my board, but I don't believe there'll be any issues with it.
Okay.
We could be fine.
All right. So you'll let me know as soon as you find out.
Mhm.
All
Yep.
right. I'm ready when you are. And we are moving, well, supposed to be moving the Kalkaska box over to Railroad Square. The village is supposed to be moving that next to the meals refrigerator. Because the Kalkaska is now going to be a daycare center. And they didn't want that sitting outside the door of the daycare center. So we'll update that map as soon as we move that and hopefully place that new box over at the COA. We're really excited about coming into the COA or going into the COA next month. It's going to be a combination of medication, education for our seniors, some giveaways. I'm thinking some lock bags, maybe some medication boxes or pill boxes, something that they'll use. And then we're also going to be kicking off the DEA National Medication or Prescription Medication Take Back Day. So we do it for about a week because it is Trout Festival too. So people are busy. So we encourage people to drop off their medications at the Sheriff's Department to and from Trout Festival during that week. And that's the Trout Festival week. So that's what, April. We're going to kick off on April 21st and it'll run through the 26th. And we'll do a before and after wait. And that's thanks to the Sheriff's Department. And so, any other questions or comments, or did you learn anything? Anybody want to point out something that they might have learned that they didn't know?
I just want to say thanks, Dr. McGreaham, for the great information. I got to head out here in just a minute, but I appreciate what you said too about the screenings. It makes me appreciate my doctor. I had anxiety, I don't know, maybe a decade ago, but every time I go, he gives me the GAD-7 form, and I get to fill that out. And I always tell him I appreciate him doing that, right? Because it's who knows when those things and pop back up. And I think sometimes with substance use, doesn't always get asked. And so I'd rather, professionals ask than not ask, right? So the fact they talked about more screening, I think is never hurts to just ask the question. And if we did that more, I think more folks might be able to get screened out and get some help. So thanks for bringing that up.
Yeah, and so Undersheriff Wagner and Bill, what could I do as a prevention specialist in Kalkaska County to help you with some of these overdoses?
I believe the first thing is not just the seniors, but everybody, but seniors particularly would be the education. The COA, I think, is going to be your first outlet. I know we spoke about that earlier. Unfortunately, a lot of the people that are in that isolation category don't always go to COA, but I think COA is the first place to start with the education.
Okay.
I would agree, education, and then follow up if you do find out that there's somebody that does need help, make a referral. We're trying to kick off our community paramedic program to work with Dr. McGreaham for opiate use disorder. So there's definitely resources out there. So reach out.
Okay. What's the best way that we might be able to follow someone to individuals' homes to be able to provide that education?
I mean, I would stick with the COA. I mean, I know they'd, especially with Jody, I know they know a lot of the individuals don't even come there, but at least they use their food services.
Mm-hmm.
So then there's those people out there that could be isolated.
Okay. Nikki?
I think, Bill, what you're doing with the paramedic program, if somebody were deemed high risk by their provider or even if somebody at the COA saw somebody and they see them getting more confused or they're wondering about medications, I think they can call you and you can do a home visit.
Yeah, and
It's
we're
my
working
understanding of
on,
the program. So that's one way to get right to the home. I mentioned home care, but home care referral is not always easy to do.
right.
They have certain criteria that they have to meet to go into the home. I think the paramedic program will have a little more latitude to go check on folks.
I was thinking maybe training with the home health agencies, with the admin part of it, because then they could work with their people that are going into the homes, just what to look for.
Maybe that's something that we can work on, is to try to get some education in with meals, or who, somebody going into the homes for those who don't come to the COA. We can try to get some sort of program going, unless you guys have something already going on over there at the COA to help educate.
We do our monthly meetings with our in-home service staff that go in and do light housekeeping. So that would be a good training topic that we could have.
Okay.
And any brochures or anything that we want to hand out for our meal clients. When we do our meal deliveries, we could do that.
Okay.
And I think UK wants to do a staff training, and we'll have you do that again for a full staff training probably this summer. So that'll work too.
All right. All right, and we'll definitely be in touch. I'll be seeing you today. All right, any other questions, comments? I really appreciate everybody being on here and answering questions. Under Sheriff Wagner and Bill, I appreciate you jumping on here. I know you guys are busy. I just thought it was a really important subject that we needed to talk about and try to figure out how we can keep our seniors safe. All right, if there's no other questions, our next Coffee with the Coalition will be on Tuesday, May 26th at 9 a.m. And the topic is going to be to be determined. So I'll get that information out to you as soon as I can. Thank you again, everybody.
Thanks for having me, Suzanne.
Absolutely.
Take care.
Thanks for coming. Bye.